Thank you, Mr. President, and through you to the Minority Leader. Thank you so much, Leader Tarr, for your interest and for your collaboration on this effort. And I rise today to address your questions and to tell you about what is in this bill. So I just want to start by saying there should be absolutely no surprise to the members of this body that the Massachusetts healthcare system is seriously struggling. You've all seen the headlines and heard from your constituents and the hospitals in your district about the challenges that they face. Healthcare costs for patients and the state continue to rise, as well as the cost of delivering care. There's a lack of oversight and transparency in many healthcare sectors, such as pharmaceutical manufacturing companies and pharmacy benefit managers. Primary care is in deep, deep crisis. But most concerning of all is that we have lost the patient and their needs as the primary focus of the healthcare system. While there are many factors that have destabilized the system, the entry of profit-driven entities and models of care into the system have played a key role. The recent events concerning Stewart Health System have exacerbated a pre-existing crisis across all aspects of the system. They may not have been the cause, but they certainly are the poster child. It's been happening before them, and it continues to happen now. But we cannot measure the complete impact of these actors in the system without strengthening the oversight and reporting requirements of the major market forces. The bill before us today, an act enhancing the healthcare market review process, builds on Massachusetts' long history of bringing transparency to the healthcare system while responding to the rapidly changing healthcare landscape. What we did in 2010 in the world of healthcare was very, very different than it is today in 2024. This very comprehensive bill has a lot of important provisions in it, and I'll do my best to explain them to be concise and streamlined as possible. So the bill expands the authority of state agencies charged with measuring and containing healthcare costs and strengthens the healthcare market review process, all with the goal of stabilizing the system, advancing health equity, and improving affordability and access to high-quality care for residents. To strengthen the Health Policy Commission's work while reflecting an evolving Massachusetts healthcare system, the bill adds members with expertise in hospital administration and the development and pricing of pharmaceuticals to the Board of Commissioners. Board is tasked with setting the state's healthcare cost growth benchmark, which is the limit for how much the HPC believes healthcare costs should grow over time. The bill changes the benchmark from 1 year to a 2-year period to better account for irregularities in healthcare costs. We do a benchmark every year, but we look back every 2 years. While HPC provides policy recommendations regarding healthcare delivery, the Center for Health Information and Analysis, or CHIA, monitors the healthcare system and provides analysis on the system's performance. To increase transparency, the bill authorizes CHIA to collect information from additional healthcare entities such as private equity firms, real estate investment trusts, management services organizations, pharmaceutical companies, and pharmacy benefit managers. The bill strengthens HPC's and CHIA's ability to ensure compliance with data reporting requirements by healthcare entities by enhancing the penalties for noncompliance. Bill also moves the state health planning to HPC and the healthcare resources inventory to CHIA to better align with the work of these agencies. It is very difficult to understand a system when you don't know what you have. And this bill requires that HPC do a full state health plan so that we can understand what we have, where we have it, what we don't have, and where we don't have it. In developing the state health plan, HPC is directed to consider all of the health equity goals that we've stated as a Commonwealth. It also directs HPC and CHIA to set and measure healthcare affordability in the Commonwealth. Next, the state updates several programs aimed at constraining healthcare costs and improving the equitable distribution of healthcare resources, including the determination of need, material change notification, and the performance improvement plans. So just to be clear, the determination of need, or DON as you will hear it referred to, that process is a regulatory program overseen by the Department of Public Health to review proposals to either expand healthcare facilities or change the services they offer. This bill increases coordination between state agencies involved in this process to ensure that the Department of Public Health has all of the information it needs to more fully assess a proposal's potential impact on the provision of healthcare in the Commonwealth. A material change notice, or MCN, is a requirement for providers and provider organizations to notify HPC of a proposed change to their operation or governance structure. It adds a new type of transaction that requires an MCN, including significant new for-profit investment in acquisitions by for-profit entities, such as large for-profit physician organizations and private equity firms, as well as the sale of assets for the purpose of a leaseback arrangement. Crucially, the bill gives HPC new authority to require providers to address concerns that the proposed change will significantly increase consumer costs, reduce the quality of care, or reduce access to services. The Performance Plan, or PIP, is a process by which HPC can require entities that have exceeded the cost growth benchmark to reduce their spending. Bill provides more flexibility for CHIA to refer healthcare entities with excessive spending to HPC, which then can require a PIP. It is a can, it is a may, it is not a shall. In addition, HPC is given new authority to assess a civil penalty instead of requiring a PIP. Leading nationwide efforts, the bill also expands oversight of private equity firms, real estate investment trusts, and management service organizations involved with Massachusetts healthcare providers and provider organizations. Among other proposals in the bill, it establishes very strong financial guardrails for providers with private equity investment by limiting the amount of debt that a private equity firm can place on a provider or provider organization, and by preventing private equity firms from extracting wealth from those providers. It requires private equity firms to post bonds with DPH upon filing an MCN, and authorizes DPH to collect the bond if a provider with private equity investment goes outside of the guardrails or declares bankruptcy. Adds private equity firms and real estate investment trust and management service organizations to the list of entities that the Attorney General can obtain information from, and adds these entities to the Health Policies Commission's annual cost trends hearings. And it requires no less than 90 days notice to DPH in any case where a party is seeking to possess collateral from a provider or provider organization in the form of a medical device. We heard some of the horror stories that came out of some of our hospitals when the owners of medical equipment repossess them in the middle of a crisis or a critical incident. In conjunction with the Senate's effort to rein in costs of prescription drugs through the PACT Act voted out in November, the bill expands oversight of pharmaceutical manufacturing companies and pharmacy benefit managers, or PBMs, and creates a licensing structure for PBMs. In addition to PBMs, the bill also establishes licensing structures for certain healthcare providers currently not licensed and therefore not subject to DPH oversight, including office-based surgical centers, urgent care centers, and healthcare practices. The bill will protect clinician autonomy by limiting who can own a healthcare practice and limiting control over practitioners' clinical decisions, be it by healthcare facilities that employ the practitioners or by the management service organizations the practitioners hire for their healthcare practices, which are only supposed to provide administrative support, but go much further than that and get into the actual delivery of care. In response to an increased number of consumer reports of delays in access to medication due to the need for prior authorization, this bill does two things. It establishes a task force to study and develop recommendations to standardize and limit the use of prior authorizations, and it Then the task force is set for a very limited amount of time. They will produce recommendations, and then it will be the responsibility of the Division of Insurance over the course of 6 months to develop regulations for prior authorization that will be then used across the board by all carriers. It also requires new insurance carriers to honor any prior authorization approved by a previous carrier for at least 90 days following a patient's enrollment in the health plan, and requires that prior authorization approval for medication prescribed for chronic disease, medication or treatment prescribed for chronic disease management must be valid for the length of the prescription of up to 12 months. I'm going to diverge a little bit here. Prior authorization has such a huge impact on the most visible and completely invisible illnesses, diseases, and conditions that we see. I receive stories from patients and providers about their challenges with prior authorization for necessary life-improving or even life-saving medications at least 2 to 3 times a week. I want to tell you a few stories. Consider a nonverbal young woman with severe intellectual disabilities and minimal motor function who for years has suffered with debilitating gastrointestinal issues. 3 years ago, the condition was diagnosed and medication prescribed and covered. Her condition improved with the medication, relapsed without it, but now her insurance carrier has denied coverage of the only medication that has worked to provide some stability and improvement to her quality of life. Instead, her family now has the choice of attempting to mitigate the symptoms of relapse, mitigate a horrific and yarn ball of a system, or pay $1,500 out of pocket for a 14-day supply, or have it become so bad that she goes to the emergency room and stays in the hospital. Now consider a patient with a skin disease that progresses so rapidly you can cause fingers to fall off. One of the 2 medications that have the best chance of stopping this process in its tracks are Botox injections into the fingers, because all of the other oral medication for Raynaud's work too slow. Here's the problem. Botox almost universally requires a prior authorization for Raynaud's, and even when the provider marks this PA as urgent, insurers have sometimes come back to say that they'll urgently give you a response in 7 to 10 days. At that point, the patient had already lost their finger. Or the stories of a 20-year-old who's dealing with acne as a result of leukemia treatment, who is having success with a medication that costs just a $17 copay, who was told that insurance no longer would cover this treatment and it would cost $200 out of pocket. Hasn't he been through enough? And finally, my favorite, and the most disturbing story I heard is the following. This is from a doctor. I'm trying to get a lumbar MRI for a young man with a history of sarcoma, SP, high femoral above knee amputation, and severe phantom limb pain. The pain is 6 months old, while the amputation is years old. He has been in PT. I suspect a lumbar radiculopathy. MRI is denied because I didn't do a nerve exam. When somebody teaches me how to do a nerve exam on a leg that isn't there, I'd be happy to do it. Still trying to get a peer-to-peer, but lots of wasted time by both me and my staff. There are far too many disturbing examples of patients and providers struggling to receive necessary prior authorization from insurance carriers on medications and treatments that providers have already deemed the best course of action, and the delays and denials are frequently nonsensical. Providers, patients, and their families are forced to spend precious time to advocate for their medical needs to these insurance carriers, and often these medications have already been successfully used by the patient before the carrier have pulled the rug out from them for no understandable reason. This legislation will make significant improvements to the prior authorization process that will make the lives of providers and patients and their families hopefully less stressful. The bill also establishes a health insurance bureau under the Division of Insurance, overseen by the Deputy Commissioner of Health Insurance, with the authority to review health insurance premium rates, establish affordability standards, and consider affordability during the rate review process. And to understand how to best build a sustainable primary care system, the bill establishes a task force to study and make recommendations to stabilize the primary care system and workforce, increase financial investment in primary care, and improve patient access to primary care. Because we all know, we've heard it 1,000 times, if you want to deal with the healthcare system, if you want to make people happier, if you want to take care of cost for hospitals and specialists, make sure people have access to primary care. And finally, I'd like to highlight how this bill was crafted through a lens of advancing health equity. Health equity should not be siloed out, but instead integrated into policy and healthcare systems. With that in mind, it requires the state health plan to support goals of advancing health equity and addressing disparities in the healthcare system, directs DPH to consider health equity during any DON process, directs the Health Insurance Bureau to enhance equity access, quality, and affordability in the healthcare system, and adds health equity advocacy experience to the CHIA Oversight Council. I am enormously grateful to have been given the opportunity and responsibility to help craft this bill with you, with Madam President, Chair Rodrigues, and I am grateful to our respective staffs for their tireless work over these past several months, days, and hours to ensure the patient and their needs is put back into focus. And I want to especially thank Liz Berman, my Chief of Staff, Adelina, my Policy Director in Healthcare, Wade Homer, our counsel, and of course to the amazing and wonderful Colby Dillon and Katie Vera in Ways and Means. This was a group effort. This is an incredibly difficult, complicated, nuanced subject. It takes much investigation, knowledge, education, and most of all, patience. And I want to thank all of them, with special thanks to my staff for us being able to put such a comprehensive bill together. I'm also very appreciative for the diverse array of stakeholders that show a continual willingness to sit down with us during this process and talk through many of the concepts included in the final bill. This bill is not the end. It is not going to solve all the problems of healthcare. Many people have put in many amendments that I would have loved to accept. They're good amendments. They help consumers. They help providers. But this bill, if you don't have the infrastructure, if you don't have the foundation to be able to control or monitor your healthcare system, you can't make significant changes. I think this is what this bill does. So thank you, Mr. President. I ask when a vote be taken by the call of yeas and nays.